Okay, so we're back for the part two, excuse me. We're back for part two of the heart chapter, heart and blood vessels. In the first part of this heart and blood vessels, we talked about the structure of blood vessels, and then we talked a lot about the anatomy of the heart, and then we ended off by talking about the blood flow through the heart. Once you understand all of those, then you'll be able to really get into the cardiac cycle. So now we're going to put it all together. I strongly encourage you, let me say that again. I strongly encourage you to really know the anatomy. Know the anatomy and the blood flow through the heart, so that when we talk about the cardiac cycle, it's going to make much more sense. Okay. So the cardiac cycle is one complete cycle of the heart contracting and relaxing. One complete cycle of the heart's contracting and relaxing. If your heart beats 80 times per minute, what's a normal resting heart rate? 60 to 100? 80 is right in the middle there. So if your heart is beating 80 times a minute, then we've got 80 cardiac cycles. There's different ways you can break this down, each cardiac cycle, but we're going to keep it relatively simple. So we're going to say there's two basic steps to each cardiac cycle. So if your heart beats 80 times a minute, that's 80 cardiac cycles. And each cardiac cycle has two basic parts. Number one, atrial systole, and then number two, ventricular systole. So, as we're talking about this, let's just make sure that we can define some of the major terms. Systole is just another word for contraction. So, excuse me, when we say atrial systole, it just means that the atrial, excuse me, it just means that the atrial walls are contracting. Atrial systole. Atrial walls are contracting. Ventricular systole tells us that the ventricular walls are contracting. Systole equals contraction of the heart muscle surrounding a chamber. On the other hand, diastole simply means relaxation. Diastole means relaxation. Okay, let's get into it. A couple more where we actually get to atrial systole and ventricular systole. Both right and left contract together. So when we say atrial systole, that means that both the right atrium and the left atrium are both contracting at the same time. Okay? Another key point. When one set of chambers is contracting, the other set of chambers is relaxing. So if we're in atrial systole, at that same time, the ventricles have to be in what? Ventricular diastole. So while one set of chambers is contracting, the other set of chambers is relaxing. Another example, when the right and left ventricles are contracting, so if we're in ventricular systole, then the atria are in diastole. So it's never that all four chambers contract at the same time. When one set of chambers is contracting, the other set of chambers is relaxing. Okay, here folks, so atrial systole and then ventricular systole. I mean, have you ever heard of the heart as a, just ignore that again, I'm sorry. Have you ever heard of the heart as a double pump? I have. So what's happening is we have first atrial systole. The atrial walls contract. And while the atrial walls are contracting, what are the ventricular walls doing? When one set of chambers is contracting, the other set of chambers is relaxing. So during atrial systole, the ventricular walls are relaxing. And then we just reverse it. Then we have ventricular systole. And this is where the double pump comes in. Pump, 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 pump. Atrial systole, ventricular systole. Atrial systole, ventricular systole. Pump, pump, lub, dub. Pump, pump, lub, dub. Atrial systole, ventricular systole. Atrial systole, ventricular systole. That's really it. And when the ventricular walls are contracting, well, then the atrial walls are relaxing. So many different ways that you can try and wrap your head around it. Okay, we've got nice pictures here. I'm trying to write it out. I'm saying it. So during atrial systole, and I know this picture is kind of simplistic, but I really like how it simplifies things. During atrial systole, the atrial walls contract, and it's pushing blood through the open tricuspid and bicuspid valves into the ventricles. That is it. I like this picture because it shows you the atrial walls contracting. They're squeezing. And when the atrial walls squeeze, they contract, it squeezes the blood into the ventricles through the atrioventricular valves. Make sure you pay attention to some of the details that are on the side here. We can see which chamber walls are contracting. When the atria are contracting, the ventricular walls are relaxing to receive that blood. Which valves are opening? The AV valves, tricuspid and bicuspid. When one set of valves is open, the other set of valves is closed. So in this particular picture, while the AV valves are open, the semilunar valves are closed. Atrial systole. Well then, pretty much immediately after atrial systole, we have ventricular systole. Now, the ventricular walls contract to push blood out of the ventricles through the semilunar valves into the blood vessels. On the right side, the right ventricle is pushing blood through an open pulmonary semilunar valve into the pulmonary trunk and out the right and left pulmonary artery to the lungs. On the left side, the left ventricle is pumping blood through the aortic semilunar valve underneath this into the aorta, which pumps the blood out to the body. Again, know which chamber walls are contracting, what valves are open. When the ventricular walls are contracting, the atrial walls are relaxing. If the semilunar valves are open, the AV valves are closed. That is it, folks. I mean, of course, there's more detail to it, but a basic atrial systole. Atrial walls contract. Then we have ventricular walls contract. And then the cycle just repeats. Pump, pump, lub, dub. These pictures are quite simple, but I really like them because it shows you the chamber walls getting smaller in the appropriate chambers. It shows you which valves are open, which valves are closed. and it shows you the arrows of the direction of blood flow. It also has the deoxygenated blood, blue, and the oxygenated blood, red. Those lub-dubs, that's the two easiest heart sounds. There are more. The Korotkov heart sounds, there's a whole series, but the two basic ones would be a lub-dub. What you are hearing is the closure of the valves right after they've been open. During atrial systole, the atria pump blood through the AV valves into the ventricles. Well, immediately after, and I mean immediately after, the atrial walls contract and blood moves, the AV valves that were just open close to prevent backflow. You don't want the blood that you just pumped into the ventricles to go backwards. So immediately after atrial systole, those same AV valves that were open close to prevent backflow. And what you're hearing in that first lub sound is the closing of the AV valves. Likewise, the dub is right after ventricular systole, where the semilunar valves were just open, but now they're closing to prevent backflow, and that rush of blood against the closed valve is that dub sound you're hearing. Okay, now our conversation wouldn't be complete without discussion of control of the heartbeat. I know this regulation stuff, the nervous system, what a pain in the butt, huh? Yeah. Well, we have to talk about it. If you're at rest, I'm sure that your heart rate is lower. So at rest, we don't need a high heart rate. But when we exercise, when we're under stress, then we do need a higher heart rate, right? So it's important that we're able to regulate that. I mean, I know it sounds really simple, but there has to be a mechanism in place that allows the heart to know when to speed up and when to slow down. So let's talk about that. The internal control of the cardiac cycle, and you probably heard of this, is something called the pacemaker of the heart, or the sinoatrial node. And we're going to talk about that on the next slides. So that's the internal control mechanism. And what we're going to find out is that the SA node just kind of sets its own steady tempo. Boom, 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 right? So the SA node internally sets its own little tempo. When we need to change that tempo, we rely on external control from the brain, particularly the brainstem. So the internal control keeps a steady rhythm, and a pretty low steady rhythm. I always spell rhythm wrong. Maybe I got it right here. I don't know. Right? So the internal control sets a low, steady rhythm. When that rhythm needs to be changed, then we rely on the brain to make adaptations. So it's kind of unique. In other organs of the body, the brain is always overseeing it. There's not really a lot of internal control. There's always some internal control, but the heart is pretty unique in these pacemaker cells. The sinoatrial node is able to start and maintain that steady rhythm. But then, as needed, when we need to increase during exercise heart rate, or decrease when we're sleeping heart rate, we rely on the brain to make those changes. This is really important. This really sets the stage for understanding how the heartbeat and the cardiac cycle is regulated. So speaking of that internal control, what sets that low, steady rhythm, there are There's a collection of specialized cells in the right atrial wall called the sinoatrial node. This yellow little thing right here. It's not really yellow. They're just, the picture puts it as yellow so you can see where those specialized cells sit. So that little area, just going to ignore that, that little area sets the steady rhythm. When that SA node fires, it tells the atrial walls to contract, therefore initiating the cardiac cycle. Right? The SA node sends nerve impulses to the atria that tell them to contract, thus starting the cardiac cycle. Because what's the first step of the cardiac cycle? Atrial systole. That nerve impulse will then continue through the heart. You don't need to know the other areas. If you're curious, that nerve impulse then goes down this interventricular septum to the apex of the heart, then it goes back up the ventricular walls. You don't need to know the rest of that, but where it all begins, and this is why the SA node is called the pacemaker of the heart. It starts atrial systole at a low, steady rhythm. People that have a disturbance to the SA node aren't able to start this low, steady rhythm, and they may need an external pacemaker, which is basically just an electrical device that has a lead that goes into, what color can I use? It goes into the right atrial wall where the SA node should be functioning, and it is set to deliver nerve impulses to the atrial walls, just like the normally functioning SA node would. Okay, we have some odds and ends to finish out this chapter. Honestly, I would love to talk about this much, much more, but in the spirit of keeping going with each body system per week, we got to move on. Make sure that you know the basic parts of an EKG. You might hear it called EKG or ECG. This is an electrical recording of the electrical activity of the heart. It's a really simple way. We slap some electrodes on the body. We can measure the electrical activity and interpret it and easily see when there are disturbances. Because if there's a disturbance in the nerve impulses throughout the heart, there's going to be a disturbance in the chamber walls being able to contract. You've probably seen the traditional ECG. It looks like this, and it looks like that, right? Make sure you know the basic part. The first little part there is the P wave. That blip in electrical activity relates to atrial systole, when the atria are contracting. As a whole, the QRS complex, that electrical activity is what denotes the ventricular the ventricular systole, when the ventricles contract. And then the T wave is when the ventricles relax, ventricular diastole. It should look like that. There should be a steady time in between them that's similar, right? I mean, there's so much more we could talk about, right? But let's just start with the absolute basics. There's all sorts of arrhythmias and heart blocks you could have. I give you some examples, but you don't need to know this. Yeah, I could really talk about this a lot, but I'm not going to, so we're just going to move on. If you have questions, I do have a whole nother presentation I can give you about EKG abnormalities, because I do know quite a bit about it. So if you have questions, feel free to reach out. I do want to point out, well, not for knowing, but being in the field that you are in, you have most likely used a defibrillator. A defibrillator is meant to correct an ECG abnormality called ventricular fibrillation. This is probably one of the worst. VFib is one of the worst things that we could have. The other things, sometimes we'll see a heart block, and it may happen, like here we're missing a QRS complex, but then the heart has the ability to pick itself back up again. So there's some things that aren't as serious. We don't like to see any irregularities, but there's some things that are less serious. There's some things that are more serious. If we see a STEMI or an NSTEMI, which is ST elevation or depression, that's going to indicate an MI, a myocardial infarction. That's serious. And what's really serious is when there's so much disturbance to the electrical activity of the heart that is just complete electrical haywire, VFib. So a defibrillator is an attempt to send an electrical shock into the heart to just basically shock it back into a normal rhythm. Sometimes it can work. Okay, some other odds and ends. I mean, you take blood pressure, you know about blood pressure. We're talking about blood and blood vessels in the heart. Well, as the blood gets pumped through the arteries, there's a normal pressure. There's a normal pressure that the blood exerts against the walls of arteries. When we talk about blood pressure, we're talking about the pressure of the blood in the arteries. The high number, 120, is what's happening in the pressure during ventricular systole, the systolic blood pressure. The bottom number is the pressure of the blood in the arteries during ventricular diastole. Normally, a normal BP is about 120/80. It's measured in a pressure unit called millimeters of mercury. Now the regulations are a little bit lower, so I believe 110/80 or 70 is a more quote-unquote normal. But let's just use 120/80. Still pretty good. Okay. Something else to consider is it's not just important that we pump blood out each time we pump the heart. We have to pump the right amount out. And this relates to the control of the heart. We talked about the internal control that sets a normal steady rhythm from the SA node, and then the brainstem coming into play when we need to adapt that. If we need to increase or decrease heart rate, how much the heart beats per minute, but also the volume. So make sure you can define cardiac output. I know we're talking about some, a little bit of math here, but I'm not going to have you do any numbers, but it's a really simple way to see this relationship. So make sure you can define cardiac output. Cardiac output is the volume of blood pumped out of the heart each minute. So it's a quantity in liters, but it's the quantity pumped out per minute. And that makes sense. Cardiac output, the output of the heart. Cardiac output, you'll sometimes see it denoted as Q with a dot over it. I couldn't figure out how to do that in the PowerPoint. You might see it CO. Either way, it's equal to stroke volume multiplied by heart rate. Make sure you know these definitions. You know what heart rate is, the number of times the heart beats per minute. Well, stroke volume is the amount of blood pumped out of the heart each stroke. Not each minute, but with each cycle. So if we think about it that way, this equation makes sense. The total volume of blood pumped out per minute, cardiac output, is equal to the volume of blood pumped out per stroke multiplied by how many times we contract the heart in that minute. So we have two ways. We really have two ways to alter the output of our heart. We can contract the heart more often. We can increase or decrease heart rate, or we can alter the quantity that we bring out. We can contract the myocardium with more or less force. Everything in this has a positive relationship. So here's cardiac output equal to stroke volume times heart rate. positive relationship. If we increase the amount of blood that comes out each stroke, it increases cardiac output. If we increase how many times we beat per minute, it increases cardiac output. On the other hand, if one decreases, the other decreases. If either this decreases, that decreases, or if heart rate decreases, this also decreases. Direct relationship. Okay, I want to end this talking about a couple of disorders, and there's some I'd like you to know. Of course, hypertension is a condition of chronically high blood pressure. Now, we expect during some moments we want blood pressure to go up. When you're exercising, we want blood pressure to go up. We need it to go up to pump more blood to the working muscles. Right. But I'm talking about high blood pressure at rest. At rest, it doesn't need to be high. But people with high blood pressure have chronically high blood pressure even at rest. It stresses the walls of the blood vessels. It makes the heart work harder, which over time can lead to a whole host of problems. We can have arteries that are clogged with plaque, atherosclerosis. That plaque that built up can break free, travel through the blood vessels, and get lodged in the vessels of the brain or the lungs. You don't need to know those. I'm just giving you some information. Here's what that plaque looks like. It should be a nice, smooth blood vessel wall, but due to high-fat diet, inactivity, also genetics, high sugar diet, a whole bunch of other things, you can get a buildup of plaque, and it makes it harder. Yet the heart has to work harder to pump the same amount of blood through. An MI is a heart attack. You should know that, myocardial infarction. That's when these coronary vessels, remember? The coronary vessels are the arteries and veins on the outside of the heart that supply the myocardium. If there's a blockage in here and we can no longer supply, we can't get oxygen to the myocardium, the myocardial tissue will die. Myocardial infarction. Angina, some people say angina, it's just a fancy word for chest pain that's severe. I'm not going to ask you that. You can read about treatments for a heart attack, pretty obvious. Angioplasty, we shove a little rotor-rooter through it. We may have a balloon to try and prop open the vessel, right? Or in worst cases, we can do a bypass surgery where if that blockage is so bad, we'll just forget about it and we'll put a new vessel there. Okay, a lot of information covered. Let me know if you have questions.